Christina, introduce yourself.
Hi. Okay. Thanks for having me, Jer. I'm Christina Moores. I am a physiotherapist at the sports clinic at Winston Park, and I'm also a co-owner there, as Jer is at UTM. So I've been practicing for just over 10 years, mostly in orthopedics. And over 5 years ago, I got into pelvic floor physio. Out of interest, I was actually on mat leave, and I just always thought there was something missing to treating my back pain and hip pain clients. And I had heard a bit about the pelvic floor, because you do get not very much in the undergrad format. We just learn a little bit about the course. So I took the first course, which was a non-internal course. And then it sparked my interest from there, because they started talking about conditions that I had not ever heard of, like incontinence and prolapse and dyspareunia, which is painful intercourse. So it sparked my interest there, and I carried on and took many courses through Pelvic Health Solutions, and now integrate that into my practice. So I still treat very orthopedically, and then I sort of bridge in the pelvic floor with that as well. So yeah, I really enjoy it.
Mm-hmm. I like the intro. So just so people can understand, like, what is the pelvic floor? What does it consist of? Obviously, you don't need to go in this crazy anatomy detail, but something in layman's terms that explains what it is and what the role of that part of the anatomy is.
Sure. Yeah. So I usually have a pelvic floor model with me, but I don't at the moment. So I'm going to try something here because sometimes the visual stuff is important. I don't need to get into the nitty gritty, but I'm going to share you, and let me know, guys. Hopefully you can hear this and see this. Maybe just like a thumbs up or a chat. Say, yes, I can see that. And Jeremy can let me know if you guys can see this.
I see it. So I would assume everyone else can as well.
Okay. So so this is essentially the first layer. If you look at the left side of this diagram where the superficial structures are here, there are muscles in your pelvic floor, and they obviously have incredibly important functions. So the left side here just shows the most superficial layer, which is really responsible for sexual function, bringing blood flow into the clitoris or penis, which we'll get to the male model in a second. And then it helps empty the urethra, but it also really helps to maintain continence, which is to prevent leakage of urine or feces. So this is really it from the outer layer, and these are the structures that I work on with clients. This is another view from the inside, if you will. This is a female model, aerial view inward. So you can see that there's all this muscle around the urethra, around the vagina, and around the rectum. And a lot of these structures, if you notice, attach right to the lumbosacral area. So where the sacrum is at the back here, into the sits bones, and into the pubic bone in the front. So you can tell kind of from this diagram that it's almost like a trampoline, and it has to be able to bear a lot of force. And this is the male model. So the anatomy is actually very similar, aside from the fact that the male pelvis is a lot more narrow. And obviously there's no opening here. So the same musculature exists. It's just that it's closed here, and that's it. So from a function perspective, and let me just, how do I unshare this here? Stop share. 1 minute, guys. Here we go. Okay. Yeah, there I am again. So there are 5 important functions of the pelvic floor. The first one I alluded to is sexual function. And so the pelvic floor is meant to help maintain blood flow in the clitoris and the penis in that first layer. But in the deeper layers, they provide tone to the vaginal or rectal walls so that you experience sensation. And sometimes when these muscles are too tight, then if we're talking about a woman in particular, they have a hard time accommodating a penis or a tampon or a pap speculum that the physician would use. And so we work together to help loosen these structures so that one can accommodate that more comfortably. For a male, I see male patients that have pain into their penis, into their testes, into their lower abdomen, often driven by a tense pelvic floor too. Maybe that individual is incredibly athletic or very stiff. I treat a lot of gentlemen that sit a lot for a living, and then they run into a lot of pain around their tailbone area. And again, you can see so many of those muscles attached directly to that tailbone area. So back to sort of sexual function. The other primary function is sphincteric. So in order to maintain continence, which is to not leak urine of any kind, you need to have a strong pelvic floor, and one that can contract but also relax. So sphincteric. support function. So those deeper layers, that aerial view that you saw, like a trampoline, it supports the pelvic organs. So it supports the urethra, it supports the bladder, supports the vagina and the uterus in a female, and then it supports your rectum. So huge support function. And then the fourth one is stability. So it's one of the core muscles. So when we talk about true core, the pelvic floor is a core muscle along with your diaphragm, which is the big muscle that you breathe with, your small multifidus muscle around the spine, and then your transversus abdominis muscle deep in the abdominal wall. So those are your four core muscles, and the pelvic floor being the bottom of them. And they all work together. And then the last function is it's a sump pump. So if I'm really strong in my pelvic floor and I can help bring blood flow back from the legs back up towards the heart. So women and men that have issues with that, you'll notice things like hemorrhoids or vulvar varicosities, where you get almost like varicose veins in the vulvar area. And obviously you can see why in pregnancy, all this pressure that pushes down on the pelvic floor, a lot of women will suffer from, hemorrhoids and other things as well there. So the whole pump action of the pelvic floor turning on and off helps with that as well. So those are the five main functions of the pelvic floor, and a little intro to anatomy and how these muscles are super cool and very important to treatment.
Well, that was a mouthful right there.
I know.
Like, take a second and breathe. Just breathe. Like, so from like my perspective, like let's say a male or even a female signing up for something like this, I'd be like, well, what am I getting into? Like, is it going to be uncomfortable for me? What's the process, the procedures that you take to optimize those things? Because I'd be like, oh my God, like, what is she going to see? What is she going to do? How's it going to feel? Is it going to hurt? Can you explain a bit about that stuff?
For sure. So like from an assessment perspective, you mean?
Yeah.
Yeah. So everyone comes in with a different problem, no different than when we're treating someone's shoulder. Two people may have shoulder pain, but their reason for shoulder pain is entirely different. So you have to assess that person very, very specifically to them. So for myself, and I can't speak to other pelvic floor physios, but for myself, I always look at the container first. So that means looking at the outside of someone, I look at really from the rib cage down to their knees with regards to symmetry through their pelvis, lumbar spine mobility, hip mobility, sacroiliac joint mobility, and then all the tissue around there. So maybe that person has a C-section scar, or maybe they have a really old appendectomy or gallbladder scar. So all of that stuff will affect pelvic floor tension, believe it or not, because everything's connected to everything, right? So before delving into the pelvic floor, I always look at that first, because someone can come in with an incontinence issue and it be purely driven from a positional issue through the pelvis. Perhaps the bladder is being torqued in a certain way because of an asymmetry through the pelvis. Maybe they have a stiffness around their thoracolumbar junction, so where that mid-back converts into the lumbar spine because that area innervates the bladder. So you just want to make sure that you rule out that part first and make sure that all really moves really well. And then there is an internal component. And of course, you have to get consent from the patient with that. Any of my clients should tell you that I go super slow and at your tolerance. So usually start off on the outside. So if you remember back to that diagram I just showed you, that outer layer is where we address first. If a woman has had a child and there's any sort of tearing or an episiotomy or anything like that that was done in that area, then that's going to be fairly sensitive, even 20, 30, 40 years down the road, believe it or not. It can actually be a cause of a lot of women's issues with penetration as well. So we'll start off on the outside, always at that person's tolerance. If they're not comfortable, we back off. And I may suggest, here's what I want you to do at home on your own. Or for some people, it's not even like they can't even tolerate that. And that's okay, because then I'll just give stretches and other things to do to help with that as well. Okay. But ideally, if you're able to do the full assessment, then after you do your external part, then you would do a vaginal exam. And for a gentleman, you do a rectal exam. There is a rectal component, of course, to a female as well. So I tend to only go in there if people are having mostly back pain, buttock pain, tailbone pain in a female anyway. anyways. Okay. But in a male, absolutely, you have to access the inside muscles, and that's where you want to go. So again, everything is at the person's tolerance. So if you're worried, Jared, about people being super, tender or sore, there's always ways to round it. Sometimes it takes several sessions for a person to accommodate one finger or two fingers. But ideally, the whole purpose of that is that we're trying to do trigger point release therapy in a way, right? We're trying to normalize the tissue so that it moves better, that it has a better resting tone. So no different than getting, a massage on your upper trap. You're just sort of massaging the muscles from the inside, because that's the really only way to access them. Cool. Again, a mouthful, but I hope that makes sense.
Yeah, so totally. And you're talking about incontinence. Can you talk about what that is? And then I know there's 2 different types, and maybe elaborate on those as well.
For sure. I know, of course, you start talking about conditions as you start talking about anatomy. So incontinence is the leakage, involuntary leakage of urine of any kind. So I have women, I'll be like, so do you have any incontinence at all? Do you suffer from urinary leakage? Like, no. Okay, anything else? Well, like once every while, again, once a week, with a cough. Okay, well, that's any kind of leakage that you did not mean to happen is considered incontinence. So stress incontinence is when you suffer leakage, when you are increasing intra-abdominal pressure. So things like coughing, sneezing, laughing, exercise, that would be stress incontinence. Then you have urge incontinence, which is when you leak after a very strong urge to go to the bathroom. So maybe you don't quite make it to the bathroom. So that's urge incontinence. And a lot of people have both. That's called mixed incontinence. So stress, urge, and mixed ultimately is what I mostly see. And so with urge incontinence, I may elaborate on that. A lot of people will end up having urinary frequency and urinary urgency as sort of signs that they may have initially before the leakage comes on, and things that they're dealing with for long periods of time. And then all of a sudden they become incontinent. So if you want, Jared, I can elaborate a little bit on urinary frequency and urgency.
Yeah, you might as well. That was my next question for you.
Yeah. So urinary frequency would be any voiding that really goes beyond 8 to 9 times a day. So generally we want to go pee 5 to 8 times a day, right? So that's about 2.5 to 4 hours. Okay. So I have some clients that see me that can't go beyond 20 minutes or 30 minutes without rushing to the bathroom. And that's a big problem because, and likely that's been there for quite a long time. How it starts generally is you get we call them the just in case voiders, meaning it's 9:30. I went pee because I had to go pee. And then at 10 a.m. Oh, hello.
Yes.
Sorry, I'll.
Hi, how are you?
Uh-oh.
Can I get you to mute yourself, please? And thank you very much.
Marianne.
I can't find her, but I think we're good now.
That's okay. Okay. So just in case voiding is, like I said, if you go pee at 9:30 and then you're about to go in your car for a trip, maybe for an hour at 10 o'clock, you decide to go pee again, which a lot of people do because they feel like they just got to empty their bladder before they go on a big trip so they don't have to stop. But the problem with that is if you do that enough, you then are never really allowing your bladder to fully fill, and it sort of makes the functional capacity of the bladder less over time because we have these little receptors in our bladder that need to, as the bladder stretches and fills, it sends a signal to the brain to say, okay, I'm getting full. I need to go find a bathroom now. So if I'm prematurely going pee without my bladder fully filling, and I do that enough, then you're going to get this strong urge that happens, 30 minutes after your last void or an hour after your last void, and then you're more apt to have incontinence. Does that make sense?
Yeah, totally.
Yeah, so the two kind of go hand in hand. And so that's kind of a risk factor for incontinence. So maybe you have those patterns right now, but you don't actually have incontinence. You want to nip that stuff in the butt right now. And you really want to retrain your bladder to accommodate more urine, really.
Yeah. Yeah. And guys, remember, if you guys have any questions regarding this stuff, throw it in the chat box. I'll bring it up to Christina's attention. Another condition I'm interested in though is pelvic prolapse. Can you elaborate on that?
Yeah, so pelvic organ prolapse is a lowering of any of the pelvic organs. So the urethra, the bladder, the vagina, sorry, not the vagina, the uterus and the rectum, okay? So if you think about the uterus, and I may actually have, I have another really good photo of this. If
Share
you
that
give me
screen.
one. Oh no, hello. We're all getting used to this technology, guys. So this guy here, and then here. Let's see. Jared, can you see that?
Yeah, perfect.
Oh, okay. So, oh wait. Okay. So we'll start here because it's obvious. So the uterus will descend, and it descends through the vagina, right? Because it shares that same canal. So that's a uterine prolapse. Now there are different grades of prolapse. So grade 1, just a slight entrance into the vaginal space. Grade 2, a little lower. Grade 3 is usually right at that vaginal opening. And anything beyond that is where I refer right back to the doctor. Like, just say that person has not seen their doctor yet and they've just come to me, and I see that the uterus in this case is right at the vaginal opening or beyond. There's still a lot we can do from a pelvic floor perspective for prevention and to treat it, but it's also a good idea to send back to the doc for urogyne referral at that time. So that's a uterine prolapse. Now, this is your normal anatomy up here for female anyways. So your bladder sits right here, uterus, and the rectum. So this is a cystocele. So the bladder doesn't actually, we'll say prolapse. It's not called a bladder prolapse. It's called a cystocele, because what ends up happening is it descends down and ends up pushing on the front of the vaginal wall. And then that's what you end up seeing in a bladder prolapse or a cystocele, okay? Same thing can happen from the back, where the rectum starts to come down and then push the back vaginal wall, because they share the same wall, back down like this. So risk factors to this obviously are vaginal births, but pregnancy in general too. I have a lot of clients that have had C-sections that still run into a type of prolapse because you're still having to carry a child for 9 months. Someone that has chronic straining conditions, like maybe they're constipated all, so they're bearing down lots. Someone who has a respiratory condition where they're coughing often. Someone who does a lot of heavy lifting and they just don't have a good sense of how to contract their pelvic floor. These are all kind of risk factors for prolapse. So ultimately, it's just the lowering of one of your pelvic organs. This ship and water diagram I often describe to patients, where the ship here is a pelvic organ. Let's just say it's your uterus. You have the guy wires here, which in this case are the endopelvic fascia. So things like the uterosacral ligament, the broad ligament, things that suspend the actual organ to the abdominal wall or to the pelvic wall. And then the water being the pelvic floor. So the arrow is pointing down, just a lot of stress on that organ down. And then the guy wires, or in this case, the supports to them, start to stretch and you start to see lowering. And this is something too, I will say, when people have gynecological surgery, maybe they've had their uterus removed for a cancer or for insane amount of bleeding or something like that, they need to be referred for pelvic floor physio afterwards, because then if you look at this diagram right here, I may be covering that, but you can end up getting a vaginal vault prolapse with that because you never actually fixed the pelvic floor piece to begin with, right? Because that pelvic floor is what's going to provide counter pressure for the organs to prevent them from lowering. Okay?
Yeah, I like it. That was good. Thanks for the diagram.
No problem.
There's a few questions. We're going to get to them right after. There's one more topic I really want you to hit on, and that was the benefits of pelvic floor physio, either during pregnancy or following pregnancy. Can you elaborate a little bit on that before we get to the questions?
Sure. So I think a lot of times, honestly, even though I see a lot of men with these issues, a lot of women without children with these issues, having a child, so like being pregnant, going through the labor process and delivery process is one of the biggest risk factors, right, for pelvic floor dysfunction. So what we try to do, and there's a lot of literature to support in Europe, there's a lot of stuff going on there where they get to women immediately right after they've had a child, and even prenatally as well, so that they're trying to be prophylactic. They're trying to prevent the problem from happening. So I think we're doing a better job at that here. So ideally, we want to get women anywhere in their pregnancy. So some come and see me earlier on if they're suffering from any type of pain, or maybe they're already symptomatic with incontinence or prolapse. So we can address, you know, what is again, the container look like of you right now? What is your pelvic floor strength right now? Show you how to do those things now, so that after you've had your child, you then can start resuming these things. You can start doing Kegels about 48 hours after birth. So you're starting to bring blood flow back there, which helps with the perineal healing as well. Imagine spraining your ankle and never really strengthening it after, or working on balance afterwards. You're just more susceptible for that to be injured down the road, right? So I say to women, even if you're not symptomatic now and you've had a child 20 years ago, that sort of, I don't want to say damage has been done, but you have had an injury there that can creep up at any point in time. So we try to get to women in pregnancy to help with that. At 34 weeks, we recommend doing perineal massage to prep the tissue to know how to relax and stretch out for vaginal birth as well. And then and we technically could go over different labor postures and all this stuff too that really help things. So you don't always have to just lie on your back. You can be in a 4-point kneeling position. You can give birth in a squat. So there's all of that side as well. And then 6 weeks postpartum is when I get people to come back in so we can reassess. Usually it's after their gynecological or midwife appointment. And tissues are usually healed at that point. So we'll get back into doing scar massage, accommodation. And then of course, once everything feels good and tissue feels good, we start that whole core strengthening process so that hopefully people don't run into issues down the road. Okay.
Yeah, another good answer. And it makes sense to me. Like, you know, going back to the ankle sprain, it's traumatic to the ankle. You've overly stretched muscles. You've overly stretched nerves. You need to rehab that so you can stand on one leg and not re-sprain. Childbirth, to my knowledge, seems mildly traumatic, although natural.
Yes.
So same idea applies to that, where there's some rehab, some reorganization of tissues and all that stuff that needs to happen, right?
Absolutely. And if one has had a C-section, even though you've not had a vaginal trauma, you still have, they cut through 7-8 layers of tissue to get to the uterus, right? So it's very important that even though the surface looks healed, all the scar tissue can build all the way down to the uterus. And sometimes you'll see the scars sort of anchored down to the bladder, which again can cause urgency for people. So these tissues need to be worked on. Sometimes I will show spouses prenatally and postnatally as well how to work on this area too for their partners so that things can move along well as well.
Cool. So we have questions coming in. We'll get started with that. I don't know if we have enough time to finish answering all these questions. The good news for you guys, we never leave you hanging. I've already taken a picture of the questions. I've copied and pasted them so that if we have a chance to do another one of these, depending on how long this quarantine lasts, which I think it's going to be long enough, we'll do a pelvic floor round 2 session with Christina where we'll start tackling some of these questions, the ones that we can't answer anyway. Okay?
Perfect.
So I'm going to go to the top here. Give me a sec. I'll read the first one because we have a bunch of questions. Are there any release exercises that can be done with a massage ball for the pelvic floor at home?
Yes, absolutely. So there's these teeny tiny AccuBalls that you can get that no different than using like a lacrosse ball for your glute. You can kind of, if you imagine that sort of diamond shape of your perineum, like those diagrams I just showed you at the beginning, you absolutely could use those to kind of sit on a chair or even on the floor. With any self-release though, you just want to make sure that you are eliciting a symptom that you have felt before that is tolerable, that is not excruciating, right? We don't want to cause more injury. So it could be that you're releasing around the labia majora or that section between the midline and your sits bone. Just say like you go at your tolerance and perhaps more trigger point release for an AccuBall. Internally, I often will prescribe things like vaginal dilator sets that are different sizes. So someone who maybe can't accommodate, starting at a tampon all the way up to penis, you can get different sets that allow you to learn how to accommodate. So we're talking about breathing techniques. We're talking about learning how to contract and relax the pelvic floor, because a lot of people are actually very, very good at tightening their pelvic floor, but a lot of them are not good at relaxing it, right? So now imagine my bicep is on for like, a minute or not the whole day. And of course it's going to get really painful and then it's going to get really weak. So that tone is really important. So yes, you could use a small AccuBall. You could use a vaginal dilator set. You could even use a TheraWand, which sort of S shape so that you can insert it, and we would go over this in clinic ideally, but there's where even it comes with a decent model and instructions in it, but you can insert it in and start kind of poking around inside with where it feels comfortable. It has to be comfortable. You just want to make sure you're not doing any other issue.
We got like a whole bunch of requests. Everyone wants you to flex your bicep for the camera one more time.
Oh yeah. Just not much being done there.
Okay, so next we got, can you expand on how to train the bladder to prevent incontinence? Is this something that can be done independently, or is it a pelvic floor therapy required to hold urine longer? What steps would you recommend for someone in their 30s to prepare for their pregnancy?
Well, that's a lot of questions.
That is a lot. I mean, one thing at a time.
Can you read the very first one?
The bladder to prevent incontinence. Let's start with that.
Okay, so it's kind of alluding the whole point. It really depends on the person, right? So training the bladder to prevent incontinence. So things like I already alluded to when I talked about urinary frequency and urgency. You need to make sure that you're drinking tons of water. So we still talk around 2 liters of water. People who are worried about leakage tend to limit their water intake or fluid intake. So it's more about drinking 2 liters of water a day at least, especially if you're active, you want to even do a little bit more than that. You want to limit bladder irritants, things like excessive caffeine, so more than 2 cups a day. You want to limit alcohol. You want to limit spicy foods, things that are irritating to the bladder. So that would be something to prevent incontinence, but that's just what you're putting into it. The strengthening piece, which I think is somewhere in that question too, you absolutely can start that stuff now, but ideally you want to be able to get a good grasp of how to do a strong pelvic floor contraction without compensating using other things like your abdominal muscles, your glute muscles, or your legs. So ideally, and I can share this with you right now, doing a core breath would be something where you're lying flat on your back, your knees are bent, feet are on the floor. You take a deep breath in, and on your inhale, your pelvic floor relaxes, because if this is sort of like my piston here, as I inhale, my diaphragm descends to get more air into my lungs. My pelvic diaphragm is going to relax. As I exhale, the diaphragm recoils and pushes air out of my lungs. That is when you want to do a pelvic floor contraction. So the things to think about would be contracting the muscle you would do to hold your pee, keeping in a tampon, those sorts of feelings of squeezing and lifting with the vagina. But at no point should you feel your glutes tensing, your abdominal wall tensing. So that's where sometimes it's helpful to have a skilled person like a physio have a peek at that to see, but there's certainly ways that you can start doing that on your own. Does that make sense?
Yeah, Jared? It totally makes sense. And what I'm curious about is, how do you make sure if someone sees you in clinic that they're doing it right? Like, someone might be like, okay, I'll take that advice. I'm going to lie on my back. I'm going to focus on my exhalation to do this right. How do they know they're doing it right? Or where do you come into play? And palpate maybe to let them know they're doing the right thing?
Exactly. So where I would come in an ideal world would do a vaginal palpation, because even the gynae say it's a gold standard for how to assess, but also provide education on a proper Kegel or core contraction without compensation happening. So now, like in school, you contract your pelvic floor and you're just looking at the person's abdomen. Now, knowing what I know about what you can pick up internally. So if I put my fingers inside and I can now grade that person's contraction, I can tell how strong it is on a scale of 5, right? I can tell, is that person fatiguing after a certain number of seconds? Are they compensating? Are they not relaxing it? Because that's another thing too, right? Like someone may be really doing that really strong contraction, but then it's like, hello, let go of my fingers, right? So that's where a physio comes in and is able to give you that education. But obviously right now it's really tricky because of this situation that we're in, and maybe you're not able to see one. So you can insert your own fingers, you can insert a sex toy, you can insert a vaginal dilator set, whatever you want. If you're needing that extra internal cue to make sure that you're not overcompensating using other things. But it's a lot of mindfulness, right? It's like when you're stretching, you're trying to pay attention to a gazillion different things. When I do a Kegel, it should purely just be isolated to the pelvic floor, nowhere else.
Do you, like currently, because of what's going on right now, are you able to offer any of this stuff virtually? Does it still work, or do you wait till the clinic opens back up? What do you...
No, I've still been seeing pelvic floor patients because there's so much education that goes into it, and there is a lot of self-release that you can give people. I will often just, hand out those models to people and say, this is what needs to be done. And without me actually touching them, if I'm assessing someone, if they're a repeat patient of mine and I know their history, then it's easy to do. But if they're a brand new person, then we still can look at all the external movements. We can listen to that person's symptoms and their usual habits, and then have them do that stuff on their own and then report back to me. Oh yeah, I felt like my left bulbospongiosis or layer 1 was a little bit more tight than the right side. And then we can sort of navigate that way, even though I'm not actually touching, right?
And then I'm just going to keep going with this 16-part question. What steps would you recommend for someone in their 30s to prepare for their first pregnancy?
Right. So I'm not sure if this person is pregnant or not, but like anything, if you're not pregnant and you're wanting to prepare for that, you just want to make sure that you're obviously eating well, you're drinking lots of water, you're exercising, right? And that if you're not symptomatic right now, like it really, that's a kind of a tricky question here, because it's like, is that person symptomatic? Are they not? Ultimately, you're just wanting to make sure that you have a good stretching routine, that your alignment is good. And that's where you may want to see a physiotherapist, whether it be virtually or once we're back in clinic, just to make sure. No different than when someone goes and says, okay, I want to go run a marathon. It's prudent to go and actually have your body assessed first to make sure things are good, right?
Yeah.
So you avoid injury. But ideally, you just want to be as fit as you can be and as healthy as you can be. And then while you're in your pregnancy, assuming everything is going well, you absolutely can keep up with core exercises, Pilates type exercises, yoga. You can do a lot of lifting and exercising too, depending what kind of exercise you were doing going into your pregnancy, right? So if you were sedentary, you don't want to now make pregnancy the time that you start, working out like crazy, but you absolutely can maintain fitness then. And then, like I said, pelvic floor comes in usually around the 34-week mark with regards to educating you about the perineal area and how to massage that and work with that so that you prep yourself for delivery.
Yeah. So if someone's in their early 30s and they're pregnant, I mean, is it something where they can just go online and look up some basic, pelvic floor exercises, or would you strongly encourage they do see a health professional to see if they're on the right track?
I would. I mean, there's so many great yoga and Pilates things available right now online, but I also see so many yoga and Pilates instructors that have no idea how to contract their pelvic floor on the first time until they're shown how to, right? So I'm sort of like on the fence, because you never want to force someone to like, yeah, you have to go see a physio. But at the same point, we have excellent education on this stuff, and this is why we recommend it. So in an ideal world, yes. Yes, okay. You'd want to see a physio. There was something here I saw about, can you do Kegel exercises wrong, where it makes your condition more issues? And that's sort of what I just wanted to tap on that, because that was something that we had said, Kegels are not one size fits all. When your doctor says, oh, you have incontinence, go do Kegels, and they don't even touch you or look at you, then that's a problem, right? Because you could be leaking because you are too tight down there. So doing Kegels will continue to fuel up your issue. So it's about assessing the tone, assessing the person, what they need. Maybe they need to spend a lot of time relaxing and learning how to let go of their pelvic floor before they go back to strengthening exercises. Maybe they're super hypotonic, meaning really lax inside. And yes, a Kegel is important for them, but sometimes they have no idea how to even find it. So this is where seeing someone like me could be very helpful.
I agree. And like just going back to like physio school and being able to do a proper core contraction, like the transverse abdominal muscles, to be honest, I needed someone to help me with it at the beginning. If I was going to learn how to like contract my pelvic floor properly, I would need some palpation and some feedback as well. So if I need that, and I'm pretty in tune with my body, I'm assuming someone who's in a pregnancy stage where the tissues are stretched and they might not have as much feedback, that help from a professional is giving some good palpation would be helpful, right?
Absolutely, for sure. I remember like the whole transversus abdominis contraction, contract the muscle, pretend you're trying to put in a tight pair of pants, right? And so I find that Pilates instructors and yoga instructors tend to lead with that. And that's not bad when you have a really good sense of your body, but most people have no idea what you're talking about. So if you switch it to something where you do it 5 to 8 times a day, I go pee 5 to 8 times a day, hopefully no more than that, then they will be a little bit more in tune with what that feels like to stop midstream, for example, and so it's just an easier cue to give. And when you turn on your pelvic floor properly, it co-activates the transversus anyways.
Yeah.
So yeah.
Can pelvic physio help with sphincter spasm in case of anal fissure?
Yes. So with an anal fissure, you just want to make sure that it's not infected in any way, anything like that. I've treated a lot of people with fissures, because with fissures, like any other trauma, it creates tone in the external anal sphincter. So then people end up running into voiding issues where the stool doesn't fully come out because there's this pain cycle, right? Generally, people with fissures either have one extreme of constipation or the other extreme of IBS and diarrhea, that kind of thing, right? So it can certainly help with releasing the tone in the external anal sphincter. We could even, through this sort of dialogue, tell someone to palpate or touch their own sphincter in the shower. It's very easy to access. It's one of the first layer muscles. So you can find some special tone in that area. If that external anal sphincter has too much tone in it, then it will, like I said, it'll contract before the stool is all out. And now all of a sudden I'm left with stool left in my rectum. That puts pressure on the bladder, causes bladder issues. So the stool piece is really important. And that's why I also really work closely with our dietitian then, because a lot of women and men that have pelvic floor problems, particularly bladder issues, generally have constipation issues too.
Okay.
Not all, but many of them do. Yeah.
You got 30 seconds for this next one, and then I'm going to close it up. And I kept track of where we ended up, but Jumi, we didn't forget about you. So what if you wake up at night and urinate 3 to 5 times? Does that indicate a pelvic floor or bladder problem? I've had a sleep study and nothing was unusual.
Yeah. So, and sometimes I always say to people, generally people come to me after they've seen their doctor. If they come to me and that's something they report, I obviously through the subjective will try to figure out if that's something we need to send back to doctor for. But generally you want to talk to your doctor if you have any changes in your voiding habits, your vaginal discharge, if you have fever, chills, pain with urinating, pain with sex, mention it to your doctor, right? Just to make sure it's not an issue. There are cases where I've actually had to send people back. They're not getting better with traditional pelvic floor muscle training, and I'm like, there's something going on here, and it turns out to be a structural problem. Very rare, but it can happen. So based on that, yes, I've treated many people that get up, that's called Nocturia. They get up in the middle of the night several times to go to the bathroom. And it's a little bit about looking at the whole day and what your voiding and fluid intake looks like in the whole day. And then trying to tweak things, change the habits, change the behavior. So absolutely, it can be a pelvic floor problem as well as a behavioral habit problem. Okay. Yeah.
Thanks for rushing through that last one, guys.
Sorry.
Thanks for joining. There's probably about 30 seconds. This is going to get closed down. I copied and pasted the rest of the questions. That'll be for part 2. This Saturday at 11 a.m., we have Peter, our sports psychologist, that's coming on. He's going to talk about mental health issues in relationship to performance, athletes being stuck at home during these crazy times right now. So tune in, guys, on Saturday at 11 a.m. I'll send out an email and a promo video